cause type 1 patient to be using more insulin. These insulins, one major side effect is the hypoglycemia. So let's quickly do that. I'm trying to get the whiteboard. So, okay, so can you see the board?
Yes, please.
It's difficult writing this hypoglycemia. So let's one of the complications of type 1, we get DK, and also we get hypoglycemia. And these hypoglycemia will come as a result of the use of this insulin. And I'm saying type 2 patient can also come with hypoglycemia. The reason may also be the use of the oral agent. So for type 1 comes as a result of the use of insulin. A type 2 could come as a result of the use of the oral agents. So these long-acting sulfonylurea, long-acting. Example of the long-actings are what? I'm saying that for type 1 could be as a result of insulin. For type 2 could be as a result of long-acting sulfonylurea. What are some of the examples of long-acting sulfonylurea? Any agents that you know? So Dionyl, glibenclamide, Dionyl is long-acting. These sulfonylurea can those. So we have different definitions for hypos, varying definitions for hypo. Last time, one of their questions, I was asking them to give me the WHO definition for hypoglycemia. They were writing essays for me. The WHO definition for, so who can tell me the WHO definition for hypoglycemia? Who can tell me the WHO definition for hypoglycemia? Who can tell me the definition for the WHO? Class. The WHO definition for hypoglycemia. Okay. Nobody's telling me. Hillary.
Dr. Atakra, please, I'm not sure.
You don't know. Tell me what you. If you tell me you're not sure, it means you know something. You're not sure whether it's the WHO. So tell me what you know that you are not sure.
Levels below 3.0.
So the WHO definition for that. I asked this. One of my questions, professional exams question, I was asking about the WHO definition for hypoglycemia. They're writing essays for me. But what you should know is that we don't have any WHO definition for hypoglycemia. We don't have that. There is no WHO definition for hypoglycemia. So that should be the answer. No WHO definition for hypoglycemia. But when the levels dropped below 3, when the level drops below 3 millimole per liter, then we say that patient is having this. But this is not the WHO definition. So note this, we don't have the WHO definition for hypoglycemia. But we say that when the level drops below 3, then you'll be getting hypoglycemia. When the levels drop to 2 millimole per liter, then it will affect the brain. To affect the brain and to also lead to a certain type of condition that we'll be talking about. So hypoglycemia basically means that when the level drops 3 and below, you'll be getting hypoglycemia. And when a patient gets hypoglycemia, we have what you call counter-regulatory hormones. Counter-regulatory hormones. And these counter-regulatory hormones would alert the patient, will tell the patient that the patient is having this hypo. Patient sugar level is low. This alertness will prompt the patient to go and look for sugar and take that. So these counter-regulatory hormones would cause this clinical manifestation or the symptoms that will alert the patient that the sugar level is low. So what are some of these counter-regulatory hormones? Hypoglycemia is as a result of dropping of plasma glucose level below 3 and below. And when these dropped, the counter-regulatory hormones will alert the patient that your sugar level is low. And what are some of the counter-regulatory hormones that will alert? Who can tell me some of the counter-regulatory hormones?
Glucagon, cortisol.
Glucagon, cortisol,
Norepinephrine.
adrenaline. What again? We have growth hormone. But the one that would prompt us out of this, the one that will prompt us is the sympathetic arm of the autonomic nervous system. The one that will prompt us. Glucagon will cause increase, will stimulate and cause the liver to increase the sugar level. Cortisol will also do that. But the one that would prompt you is the sympathetic arm of the autonomic nervous system, the adrenaline. The adrenaline is the one that will prompt you. So patient will be coming with certain clinical manifestations, and that would alert you that, hey, your sugar level is low. So note this, that is the counter-regulatory hormones that would prompt you. And the most of these, one of these counter-regulatory hormones is the sympathetic arm of the autonomic nervous system, or the sympathetic activities that will prompt the patient to show these to show that the patient is having low levels of sugar in the system, low levels of sugar in the system. Okay, so if a patient goes into hypo, tell me, what are some of the causes that could put a patient into such a condition? Patient goes into hypo, what are some of the causes that could push the patient's sugar level to be below 3? What are some of the causes? Causes of hypo?
Starvation or fasting for long periods.
Starvation or fasting. Starvation or fasting. Any other?
Use of insulin.
No, if the okay.
So do it in this way. Do it in this way. I like that organization. So causes. If you are talking about what are some of the disease conditions that could lead to, it could be a disease condition, it could be medication, it could be lifestyle. Do you get it? Class, do you get it?
Yes, please.
So
Yeah.
what are some of the disease conditions that could lead to such that we won't mix them? What are some of the disease conditions that could cause hypoglycemia?
Someone with a liver disease.
So someone with liver disease could easily be getting this. Someone with liver disease. Any other?
Severe malaria.
Severe malaria. Severe malaria. Severe malaria can push a patient to. So tell me how severe malaria can do it.
So please, in severe malaria, the patients usually have vomiting, severe vomiting. So there's poor feeding. So it means they don't eat well, and then the red blood cells also make use of the glucose stores in the liver. So it can push the patient to get hypoglycemia.
So you're telling me vomiting. So if a patient is vomiting, normally what will come into our mind is it's not the food. Do you get me?
Yes, sir.
We look at the fluid loss more than the food. If you are vomiting, means that maybe so let's take the disease condition and see that whether that disease condition can push us into hypoglycemia. Then if you are talking about vomiting You look at vomiting more of, you can vomit what is within the food that you have taken. You can vomit. But when a patient is vomiting, we are looking at more of the fluid loads. You can also look at the electrolyte loads more than the food. But as you said, poor diet as a result of severe malaria could also lead to that. But poor diet as a result of this severe malaria could also lead to that. But if you take the malaria itself, unless you tell me, if you take malaria itself, that malaria will not lead to hypoglycemia. Assuming you have malaria and you are being given glucose, you are being given, if the patient is vomiting and you are giving parenteral or IV glucose, the patient will not get what? Hypoglycemia. Please, you get me?
Yes, sir.
If you take liver, the condition itself could lead to that. The condition itself could lead to that. But if we take, as you are saying, malaria, the condition itself will not lead to that. But the aftermath of the condition, if severe malnutrition will be vomiting, patient cannot take something. The disease condition itself is not, but what is surrounding the condition could lead to that. So liver disease more, I'll go for liver disease more than the malaria. I'll go for liver disease more than the malaria. Any medications that could do that? Any medications that could do that?
Quinine.
So that malaria aspect, if you mention quinine, the use of quinine when a patient gets malaria is good. Quinine does this. Quinine will stimulate, will cause the release of insulin. The pancreatic beta cells to release more insulin, and this can drop the sugar. So quinine, very important. Quinine can cause hypoglycemia. Any other medication?
Insulin.
Insulin, good. Insulin can cause hypoglycemia. Any other? Any other? Come again. Hilary, can you tell your colleagues to mute if they are not answering the question?
Kindly mute if you're not answering a question, please.
Okay, so lifestyle. Tell me how lifestyle could also cause hypoglycemia. I could set a question and ask you, put this in this category. State about 3 medications. Tell me, say 3 lifestyle that could push the patient into hypoglycemia. Talk about disease. Mention 3 disease conditions that could push a patient into hypoglycemia. So lifestyle. What are some of the lifestyle? Malnutrition. Somebody talked about starvation. So lifestyle, malnutrition is a lifestyle. Tell me the lifestyle. Excessive alcohol intake. Excessive alcohol intake is a lifestyle. Excessive alcohol intake. What excessive alcohol does is that excessive alcohol would impair gluconeogenesis. It will impair gluconeogenesis and can push the patient into this hypoglycemic state. Excessive. So please note what I am saying. Note that you can say state 2 or 3 conditions. State 3 lifestyle that could push a patient into excessive alcohol intake. Any other lifestyle?
Excessive exercise.
Come again.
Excessive or vigorous exercise.
Excessive.
Exercise.
I can't hear you.
Excessive exercise.
Excessive exercise. Good. It's a lifestyle. Good. Excessive exercise. Excessive exercise could also lead to that. What again? Even concerning your food, not eating right amount of carbohydrates, not eating right amount. Just yesterday, a diabetic patient was complaining to me about these intermittent hypos just yesterday. So I was asking her what she'll be taking. She'll be taking at that night. And he said, oh, she'll be taking tilapia. And she likes tilapia at night, so he takes tilapia. I look at her and I say, wow. I told her that tilapia is basically protein. You need carbohydrate, you need glucose. So if you take the tilapia alone, could push, and you're on your medication, could push it. You need amino acids and you need glucose, sugar in the system. So if you are not taking even right amount of this carbohydrate and you're not taking at the right time, all this lifestyle could push you into it, into hypo. Please, you get me?
Yes, sir.
You get me?
Yes, sir.
So make sure in your counseling, when you are counseling diabetic patient, to make sure, because of the risk of hypo, these things are very important. Now, taking the food, you think that I'm taking so much protein, you are leaving you are leaving the carbohydrate components. I like this. So in terms of dieting, you should cancel them. Dieting, you should cancel them. So not taking right amount and at the right time will also push the patient into hypoglycemia. So these are some of the causes. Some of the causes of hypoglycemia could be medications, taking these sulfonylureas, taking these insulins, long-acting sulfonylurea, taking these insulins, not eating at the right time, the right quantity to do that. Excessive exercise, certain conditions. So all these could push a patient into what? Into hypoglycemia. Certain patients will not respond appropriately to these hypoglycemic conditions. Certain patients will not respond appropriately to this. Who can tell me some of the reasons why certain patients will not respond appropriately to hypoglycemia? Please, you get my question.
No, sir. Please clarify.
certain patients will go into hypo and they will not be aware that they're having hypoglycemia. They will not respond appropriately. Because if I don't know, how do I respond appropriately to? Do you get it? If I'm not aware of this, how do I respond? So what are some of the reasons why patients will not respond well to or react well to hypoglycemia? What are some of the reasons?
Patients on beta blockers.
Patients on beta blockers. Patient on beta block. Why is it that patients on beta blockers will not respond appropriately to hypoglycemia? Why is it so?
So because the side effects of beta blockers mimic the signs and symptoms of hypoglycemia.
Come again. Come again.
Please, I said because the side effects of beta blockers, some of the side effects of beta blockers mimic the signs and symptoms of hypoglycemia.
What are some of the side effects of beta blockers? Let me make that. What are some of the side effects? Oh, hurry up, hurry up.
Sir, please, we have sweat, palpitation, and tremors.
This will mimic. The first person was telling me that side effect of beta blockers will mimic hypoglycemia. I want to know those side effects of beta blockers that will mimic. Because of the orals, please, you should be able to say A, B, C, D to me because of the oral. Oh, so who can explain to me why patients on beta blockers will not respond?
So, beta blockers, they mark the symptoms of hypoglycemia because they block the effect of norepinephrine. So when that happens, there's going to be low
Come
heart.
again, because your line was dropping.
So beta blockers, they mark the symptoms of hypoglycemia in that they block the effect of norepinephrine. So when that happens, you're going to get a slower heart rate and reduced tremor.
Your ending, I don't like your ending. Because of that, they would slow heart rate and reduce tremors, meaning telling me what? You have the fact. So when you get such a question oral, make sure you get it right. You have the fact. So come again, please.
So beta blockers will mask hypoglycemia because
So
they are going to
what you should start in such a question is that the clinical manifestation or the signs and symptoms of hypoglycemia is as a result of the sympathetic activity. You get me?
yes, please.
So it's the sympathetic activity or that would cause these clinical manifestations when a patient goes into it, hypo. That should be, you should make that thing clear. So some of the clinical manifestation, then you mentioned will be palpitation, tachycardia, sweating. These are all these clinical manifestations are as a result of that, of the sympathetic effect, prompting the patient. You should make that thing first for us to know, then continue. Continue, please. Hello? Continue.
So
Are you done?
when a person goes into hypoglycemia, some of the sympathetic manifestations include tremors, tachycardia, palpitation as a result of norepinephrine release, and beta blockers is going to block norepinephrine. So when that happens, there's going to be reduced tachycardia and palpitations. So the patient will be prompted.
So the beta blockers would block these sympathetic effects, and therefore there won't be any tachycardia, there won't be any palpitation, there won't be any sweating when the patient goes into hypo. And therefore, we say that beta blockers will mask the hypoglycemic symptoms. So diabetic patients on beta blocker is a caution. Diabetic patient on beta blocker is a caution and not contraindication, because it's a caution because beta blockers may mask the hypoglycemic symptoms. They will do that by blocking these adrenaline effects. Adrenaline would cause this clinical manifestation, such as palpitation, such as sweating, such as tachycardia. Because beta blockers will block that. Patient going into hypo, you will not be seeing this clinical manifestation. And therefore, patient will not be able to respond appropriately to that. Any other? So why is it that patient will not respond appropriately to hypoglycemia?
So please, can you say unconscious patients?
Unconscious. Okay, so let's add it to it. Unconscious patient. Patient who is not conscious will not respond appropriately to that. Any other? Carry on. So if a patient is not responding appropriately to hypoglycemia, we term it as hypoglycemia unawareness. Hypoglycemia unawareness. If a patient is not reacting to hypoglycemia appropriately, we use the term hypoglycemia unawareness. So if I ask you to give me some reasons, 2 or 3 or 4 reasons why patient to be having this hypoglycemia unawareness. So we have talked about patient on beta blockers. I've talked about unconscious patient. You should be fasting this. If a patient comes with neuropathy, can a patient respond well to hypoglycemia? Class. So patient cannot respond to that. Educational failure. Educational failure is also another. If you don't educate, why? Okay, so why am I saying educational failure? Hurry up. Why am I saying educational failure will let the patient not to respond well? Are you there?
Yes, we are.
So
It
tell
could
me,
be two things. Either the
I'm listening. Hurry up, please.
It could be
okay,
that
so I
the
was saying
patient
that it
was
could be
not
two
properly
things.
told.
Either the patient has not been told of the various signs and symptoms to expect in hypoglycemia, or even when the patient is being administered insulin, the counseling of the right after administering or admin 15 minutes, and their food should be ready. Probably that counseling was not given properly, so the patients can easily take.
So when you are counseling a patient, there should be a proper counseling. Proper counseling. Tell the patient about these autonomic symptoms. Counsel the patient autonomic symptoms. So counseling, if you fail to counsel a patient well, then another last thing I'm talking about is when a patient comes with recurrent hypoglycemia. Recurrent hypoglycemia. If a patient is having a recurrent hypoglycemia, it will also not help the patient to respond appropriately to hypos. Recurrent hypoglycemias will not. Because if a patient is having a recurrent hypoglycemia, the system will become used to, and therefore the system will not respond to this sympathetic effect again. If you come to the class every day and your lecturer will be slapping your face, every day you'll be getting slapped, every day slap, every day slap. Your system will become used to the slap. But when I come, I'll get one slap. When I come, I'll get one slap. Your system will become used to. At times, you stay in a place where they have dumped this rubbish. Certain people are living closer to where they have dumped this rubbish dump areas. When you are new and you get closer to that place, you could feel that the place, the scent in that place. But those who are living there they have become used to. So they don't feel anything. They don't nothing. They live normal like you. The system has become used to that. So when the system is getting recurrent hypoglycemia, time will come, they will get hypoglycemia, but still nothing. They will not. The system will not feel anything. So recurrent hypoglycemias can also. Patient on taking alcohol intoxication can also cause hypoglycemia. Not to let the patient becomes aware. And I don't know whether you call something in our local dialect, you call it inkiti. Have you heard of this? Those who takes alcohol and sleep, they say that these patients normally at risk of getting these condition. They call it local dialect as inkiti. Have you heard of this before? Have you heard of this?
Yes, sir.
So this as a result of alcohol. These alcohol intoxication push the patient into that. So that is that. Let's talk about how. How do you manage? How do you manage How do you manage hypoglycemia at the hospitals? How do you manage? Please tell me. This is something that you should know. At the hospitals, how are you going to manage hypoglycemia? In the house, how are you going to manage hypoglycemia? Quickly, tell me.
Can give blood sugar with the patient or when someone has signs of
In the
hypoglycemia.
hospital,
Oh,
how
sorry,
in the
50%.
hospital you
50%
give them
texture, 50 mils or 50%.
the 50 minutes of 50%, you push it. When the patient comes with these hypo, we do that quickly. What again can we do if we don't have 50%? What again can you offer as a pharmacist when you don't have 50%, when you don't have 10%, when you don't have, what again can you offer?
Glucagon injection.
Glucagon injection. And how much will you give? What will be the dose? Glucagon injection. If the patient can, glucagon injection. What will be the dose?
1 milligram.
1 milligram what?
Start.
And when I'm asking you this, asking how do you give it, don't only talk about the dose. 1 milligram, is it through IV? Is it oral? Is it this or this? It's what? Please, it's what? Glucagon. I can't hear you.
Intramuscular.
Glucagon.
IM.
So IM. You give IM. Let me ask you a funny question. So if a patient comes with liver disease, will you give glucagon? The patient will come with liver disease. Will you give your glucagon to the patient?
No, sir.
Yes, why? If no, why? Hurry up. Oh, hurry up. Yes.
Sir, will not be able to store glycogen, which the glucagon will convert it back to glucose.
So tell me, you said what? Tell me, come again, please.
I said the liver will not be able to store glycogen, which the glucagon will convert it to glucose.
Any other? The glucagon will not be able to do what? The glucagon will not be able to do what? Come on. The glucagon will not be able to do what? Why can't you? I can't hear you. I want you to get it right. The glucagon will not be able to do what?
I said the glucagon will not get glycogen to convert it to glucose.
The glucagon will not be able to convert the glycogen to what? Glucose. Who can do it better for me? Who can do it better for me?
Okay, so basically, glucagon is supposed to produce glucose by obtaining glucose from other storage sites such as the liver. But in the case of a liver patient, gluconeogenesis is not occurring. So glucose in the liver to circulate it to the part of the body.
I didn't get what you said, but the point is this. I'd want, please, do you know what? When I ask you a question, please do what to answer. Don't, you push me to talk before you come in. Do what to answer. You may think that, hey, you know, but hey, be careful. Be careful. Your answers, be careful. I need more of these answers such that we can direct you guys. Glucagon will only push, listen to me. Glucagon will only push the stored glucose in the liver. See, will only do that. So when you don't have a stored glucose in the liver, glucagon cannot work. It will only push the stored glucose into the bloodstream. That's what glucagon does. So if you have liver disease, it means your stored glucose will not be there, and therefore glucagon cannot work. Please, do you get it?
Yes, please.
Yes.
So that is that. How do you manage that? So patient, I'll be talking about, the last time I'll be talking about it. I'll be talking about two things, then we are done with it. With this hypoglycemia. Be careful of this hypoglycemia. Last time, a full question on this hypoglycemia. You don't know your time, so be careful. How do you manage when the patient is at home? The patient is experiencing hypos. How do you manage it? Hurry up. How do you manage it?
So you can give cubes of sugar or a very
Be
saturated.
specific. Be specific. Don't generalize it. Can give cubes of sugar, so I should give 1 box of cube of sugar. Do you want me to do that?
No, please.
So tell me, you are instructing me to do that. What should I do? Tell me, cubes of sugar. I should take 50 cubes of sugar. I should take this. Then you are telling me to specific. You are not getting me.
Dr. Saka, please, I don't know the number of cubes.
So who can tell me the number of cubes?
4 cubes.
So 4 cubes. So this is the way I want you to learn. Pharmacists, this is what you like. You like generalization, then you make it so open. Push yourself and narrow your learning down to. I like the medics. They are like that. If they are learning this, to make sure they are specific to that. We will be opening ourselves, just be open. We give cubes of sugar. You can give cubes, but you should have a number that you can give. So you should target 4 cubes of sugar. What again? What again will you advise at home when a patient comes with hypo? What again?
So girl, please, we give them a glass of milk.
a glass of milk.
Yes, please.
So this is what you are doing in your house, or in your, where do you work? You are giving hypoglycemics, glass of milk. So Coke is there. You didn't tell your patient to take Coke. You didn't tell your patient to take Lucozade. You're telling your patient to take milk. So something that we should avoid, something that you should avoid is the milk. Something that you should avoid is the biscuits. When a patient goes into hypo, avoid these biscuits. Biscuit is a long-acting carbohydrate. And when a patient is, if a patient is stable, then you can give your biscuits. If a patient is in hypo, please, we need simple sugars. And it's not advisable to give milk. Why? The milk contains what? Contains fat. And this fat can impair the absorption of what? Glucose. So you should avoid the milk. You should avoid hot drinks. You should avoid biscuits when the patient is in that hypo state. When the patient is stable, listen and listen good. When the patient is stable, then you can give your long-acting carbohydrates, which are biscuits. But when the patient is in that hypo, we give simple what? Sugars. Monosaccharides. You give this simple sugar just to quickly push them. If I ask you, a diabetic patient who is on alpha glucosidates comes with hypoglycemia. A diabetic patient who is on alpha glucosidates comes with hypoglycemics. And I ask you, what type of carbohydrates are you going to give to your patient? What type of carbohydrate are you going to give to your patient? What type of carbohydrate are you going to give to your patient?
So please, the carbohydrates which do not contain sucrose.
What type? I don't know. So you learn how to answer, I don't know. So you are telling, hey, what is this? Tell me carbohydrate does not contain, so tell me the ones contain sucrose. Listen, in orals, don't open your lifestyle like that. Don't open up like that. You invite more questions to yourself. What type of carbohydrate are you going to give? Then you be straightforward. If you say the ones that does not contain sucrose, what does it mean? What does it mean?
So please, don't give them the table sugars and the ones from fruit.
So carbohydrate, we have polysaccharides, we have this, we have this, we have this. So find out this. What type of carbohydrates will you recommend for this patient? The last I want to talk about is that when a patient goes into hypo, two clinical manifestations occur. And these two clinical manifestations will be due to, one, damage to the brain as a result of the hypoglycemia. And the second is as a result of the autonomic response, the sympathetic effect. So clinical manifestation of hypoglycemia could be due to the autonomic response, the sympathetic effect, and also be due to the damage of the hypo to the brain. So when hypoglycemia causes damage to the brain, we call it neuroglycopenia. Neuroglycopenia. A damage to the brain as a result of hypoglycemia, because the brain receives raw glucose from the blood, So if there's hypo, if a patient comes with hypo, the brain will not be able to get to this glucose, and therefore there could be damage to that. So when you have a damage to the brain as a result of hypoglycemia, call it neuroglycopenia. And another symptoms could be the symptoms of this adrenaline sympathetic effect. So clinical manifestation is divided into two. So we have neuroglycopenic symptoms and we have sympathetic symptoms. So let's talking about symptoms of hypoglycemia. The first is autonomic. What are some of the autonomic symptoms of hypoglycemia? Autonomic. Can you mention some of the autonomic symptoms of hypoglycemia to me? Hurry up. So tachycardia, good. Tachycardia, what again? Hurry up. Palpitations, good. What again?
Sweating.
Sweating, good. What again?
Hunger.
Hunger is not under autonomy. There will be other clinical manifestations apart from this. Other clinical manifestations apart from this. What again? Trembling. And there could be also pylo. There could be pylo. Neuroglycopenic symptoms. What are some of the neuroglycopenic symptoms?
Confusion.
Coma.
There could be coma. There could be confusion. Good. What again?
Blurred vision.
There could be blurred vision. Good. Blurred vision. What again?
Dizziness.
Dizziness. Good. Dizziness. What again?
Seizures.
There could be seizures. Drowsiness. Come again. So all these are, so please, I am begging you, note these things and don't chew this. Let it be part of you. I'm talking about autonomic, sympathetic. I'm talking about what will affect the brain. So you can be asking questions. Autonomic, all these are clinical manifestations of this, except. So please note these things. So these are others. The other clinical manifestation could be what? Could be numbness, could be tingling, there could be hunger, there could be headache. These are other clinical manifestations. So we have touched on the DKA and we have touched on hypoglycemia as complications to type 2. Hypoglycemia or DK could be also complications in type what? Type 1. Sorry, type 2. DK patient could also be getting, type 2 patient could also be getting DK, but they don't normally get DK. But at times you can get DK. You don't normally get DK.
Hello, Dr. Kakra.
Hello.
Dr. Kakra, when we're talking about the home management of the hypoglycemia, you mentioned that they don't give them hot liquids. Please, why don't we give them the hot one, like hot tea with sugar?
So why you? I want you to think and answer me. I want you to think and answer why you are giving the patient. It's a simple reason why you are giving the patient hot tea. Just think. You know the answer. Why shouldn't we give hot?
It can bend them.
It can bend them.
Okay.
Huh?
Thank you.
So patient hypo is aggressive for what? For these sugars. The cells are yearning for. And we are giving hot something to. So if the patient would forcefully take these things, it will bend them. So it's not advisable to give them. It's not advisable to give them milk too. It's not advisable to do that. Is it clear?
Yes, please. Thank you.
Okay. Any question? Then I'm moving to type 2. Any question?
Dr. Takra, please, apart from the 4 cubes of sugar and then the glucose-containing drinks like the Lucozade, are there any other acceptable home remedies?
Like, what are acceptable home remedies? Like fufu.
No, please. Like I'm saying that apart from these two, can you give
I
like
want you
honey,
to mention those things to me.
like honey or something?
All that we need, listen, all that we need are simple what? Sugars. Monosaccharides, simple sugars. Simple sugars will not be broken to any other. That is what the body takes. Mono, we need mono. So if you have anything, we don't want to use the di and the poly because you need it to, there should be a breakdown of these to die and you get to the mono. We want, it's like this. We have done type 1. It's like this. Have you done thyroid gland at school? Yes or no? Yes or no? You have done thyroid gland.
Yes, please.
You are afraid of the question. That is why you cannot do. If a patient comes with maxi edema coma, if a patient comes with maxi edema coma, between T3 and T4, which one will you prefer to give and why? Maxi edema coma. What is maxi edema coma? They are thinking, they are searching for it.
So it is a severe form of hypothyroidism.
So you are checking it. Oh, you're checking it. So if a patient comes between T3
No.
and T4, which one would you give and why?
T3.
Why T3, not T4?
T4 is a prohormone that has to be converted to T3 before it can act, but T3 is already active.
So T4 is what? It's a prohormone. So you need to convert the T. You need to convert the T what? T4 to T3. So I would prefer to do the T3 because T3 is the active one. So if something happens and the conversion does, if I give T4 in emergency, this is an emergency condition. If I give the T4 and this does not convert to T3, to T3, then I will not be helping my patient. So you need to give the T3. So if a patient comes with hypoglycemia, hey Larry, all that I'm saying is that if your home remedies, if you have fufu, which is made up of monosaccharide, simple sugars, then you can give. Do you get me?
Yes, please.
It's all that I need is a simple sugars, something that the body would just take it straight away. It's not something that we need to convert it to the active before the body can take it. You need something that the system can take it straight away. This is what we need. That is why we are not going to do polysaccharide, do starch. In when the patient is stable, you can do your starch. Take your cassava when the patient is stable. But in emergency, hypos, emergency, don't go and give your starch. Give your simple words, sugars. Do you get it?
Yes, please. Thank you.
Okay, so let's move on to type 2. So type 2. Type 2. So for type 2, all that we know about type 2 is that for type 2, there's an amount of beta cells. There's an amount of beta cells. This is telling me that that beta cells, we have an amount of beta cells. Those beta cells, listen, will produce insulin. But those insulins that are produced from those beta cells are not enough to push glucose into the cells. I keep on telling you this, that diabetes is hyperglycemia in the blood. Hyperglycemia in the blood. This hyperglycemia in the blood is not being pushed into the cells. It's not being pushed into the cells. It's in the blood. And therefore, if you don't have enough insulins to push them into the cells, there will be hyperglycemia. So they are getting hyperglycemia because they don't have enough insulins to push them into. What are some of the characteristics? Some of the characteristics of type 2 diabetes, knowing that type 2 diabetes, they have some amount of beta cells, and those beta cells are not strong enough in terms of the secretory power to produce insulin, and for those insulins to push glucose into push such that you'll be getting this normal glucose level in the blood. What are some of the characteristics of type 2? So we talked about for type 1, we said that it affects younger generations. Type 1 affects younger generation. What of type 2? So what are some of the characteristics of type 2? Who can tell me 1 or 2, 3 characteristics of type 2? What are they? Oh, class, tell me, what are some of the characteristics of type 2?
Type 2 diabetes usually occurs in older aged people
The
compared to
age,
type 1
age
diabetes.
of the onset is what? Age of onset. The onset age is what? So it's greater, usually it's above 40 years. 40 years. Type 1 normally is 30 years and below, type 1. Type 2 normally 40 years and above for type 2. So for age of onset, it's 40 years and above. What again? Hurry up. Oh, hey, class, are you all participating? For type 2, you should be able to tell me this. For type 2, you should be able to tell me what are some for type 2.
Most of the patients are.
Come again.
Normally, the patients are obese.
Patients are obese or overweight. Patients, so type 2 patients are obese or overweight. If I depend on you, you are going to sleep here. So patients are obese, overweight. What again? There's a very strong genetic linkage. In type 2, I mentioned the characteristics. And to you people, you don't know. I can say regarding type 2 diabetes. Regarding type 2 diabetes, A, then I will say the age of onset is 40 and above. The moment, I've told you this, the moment we talked about regarding something, regarding Hillary, anything I'll be saying about Hillary is the truth. Regarding this, regarding type 2, when I say the onset of age is 40 years and above, then it's true. When I'll be saying it's genetically, genetical linkage is strong, it's true. So anything I'll be saying, the odd one, which is not true about that type 2, will be the answer. So we have mentioned genetical linkage. We have mentioned the obesity or the overweight. We have mentioned the onset. So type 2 also, they have slower onset of clinical manifestation, slower onset of symptoms, type 2, slower onset of symptoms, slower onset of symptoms. So no, in type 2, there won't be no beta cells distraction, no beta cells distraction. No beta cells distraction. Therefore, they won't see any cell antibodies, no islet cells antibodies. Normally, for type 1, there's antibodies, islet cells distraction. And this mainly is due to autoimmune condition that will produce antibodies. The system will produce antibodies, and these antibodies will fight against the islet cells of the beta cell. Islet cells of the beta cell. So for type 2, you can control type 2. You can control that type 2 using that. And using oral hypoglycemic agent. I'm saying characteristics of that. So for type 2, extreme hyperglycemia for type 2. For type 1, extreme hyperglycemia will cause diabetic ketoacidosis. Extreme or severe or extreme hyperglycemia will cause, in type 1, will cause diabetic ketoacidosis. In type 2, extreme hyperglycemia will cause what? In type 2, extreme hyperglycemia will lead to a complication called what? So tell me, will lead to what? Extreme hyperglycemia will lead to what?
Hyperosmolar hyperglycemic state.
Hyper.
I'm listening.
Hyperosmolar hyperglycemic state.
Hyperosmolar.
Hyperglycemic state.
So extreme. So these are some of the characteristics. In extreme or severe hyperglycemia. In extreme or severe hyperglycemia, this is the condition. It could lead to HHS. Could lead to HHS. Good. These are some of the characteristics of what? Who can tell me some of the causes? Some of the causes of type 2. Causes of type 2. Can you tell me some of the causes of type 2? Oh, hurry up. Causes of type 2, they should be able to tell me. It could be genetic. We said it's strongly linked to genetic, and 2 could be environmental factors. Environmental factors. So could be type 2 is strongly linked to genetics. So if your parents both are having diabetes, then the probability that you be getting diabetes is high. So genetic. What are some of the environmental factors that could lead to type 2? What are some of the environmental factors that could lead to type 2? Are you there?
Yes, please, we are here.
So tell me. So we can talk about age. We talked about 40 years, those 40 years and above. 40 years and above, when you are aging, then the body will be losing the beta cells. The body will be losing the beta cells when the patient is aging. And therefore, when you are losing your beta cells as a result of aging, then you'll be prone to getting what? The type 2. Environmental factors. Lifestyle is also part of the environmental. Lifestyle. If you like taking in fatty foods, obesity, obesity, obesity. Why obesity will cause type 2? Obesity will cause type 2 why? Because these fats accumulating in the system will oppose the peripheral action of the insulin. So this would affect the action of insulin. Affect the action of insulin. And therefore this can lead to what? Type 2. Can lead to type 2. Please,
No,
is
Dr.
it clear?
Please, I want a clarification. And please, when you're talking about the environmental factors, you mentioned age. So I just wanted to know if the age falls under the environmental factors.
Falls under. I was talking about lifestyle falling under environmental. Huh? Are you not part of the environment?
Yes, sir.
Are you? Or you are in the moon? Madam, are you in the So you are part of the environment. And that's why I say lifestyle is also part of the environmental factors.
Thank you.
So obesity will lead to type 2. Sedentary lifestyle will lead to accumulation of. So all these are environmental factors. Part of what? Part of the lifestyle, which is under the environment. So there's something I want to teach you. Very important. Very, very important. We are talking about this. We talked about this. If I want to know from you. I was talking about this. Obesity will lead to peripheral resistance. Sedentary lifestyle will lead to accumulation of fat at the periphery, and this would affect insulin action. So if I ask you, why do you give statins? Why do you give statins? How do you give statins to a diabetic patient? What would be your simple answer? What would be your simple answer? Why do you give statins to a diabetic patient? What would be your answer?
To reduce cardiovascular risk.
I can't hear you. I can't hear you.
to reduce cardiovascular.
It will cause what? Oh, I am not getting your answer. It will cause what?
To cause a reduction in the triglyceride levels.
It will cause what? It will cause what? Why are you
Reduction
giving
in triglyceride levels.
reduction? So diabetic patient is coming. Why do you bother yourself with the lipids? Why do you bother yourself in the lipids? It's diabetes. Why are you giving statins? Please, you get me.
Yes, please.
Diabetic patient comes. And you should concern ourselves with the glucose. Why are you thinking about the lipids by giving what? By giving statins.
So could it be because people have dyslipidemia issues?
You are asking me or you are answering me?
So, okay, please, due to they're at risk of having dyslipidemia issues.
Why are they at risk of having dyslipidemia? And again, we also say this pleiotropic effect. Additional
cardiovascular risk in the patient.
Additional thing that we also say about statin is that we also say statin. Okay, tell me the additional benefit of statin aside the lowering effect. What would be the additional benefit of statin?
It has an anti-inflammatory effect.
Anti-inflammatory. What again?
Antiplatelet.
Anti what? Platelet effect. Come again, antiplatelet effect. What is that? Hey, once you the mommy. So we want to learn something and you would appreciate why we say that statins has these additional benefits. You'll be appreciating all these additional benefits. It's as a result of certain things that will happen. So if I ask you, why do you give statins to a diabetic patient? The simple answer I was expecting from you is a simple answer, but a big explanation. The simple answer is that it will reduce. Statins will reduce C-reactive protein. This is the simple answer that I want from you, and it's a big explanation. Statins are given to a diabetic patient to reduce C-reactive protein. This is a simple answer, but it's a difficult. The explanation is big. Why do you give statins to a diabetic patient? To reduce the C-reactive protein. Why am I linking C-reactive protein to statin? What do you use the C-reactive protein for? What do you use the C-reactive protein for?
I know that it's a marker of inflammation.
It's a marker of inflammation. So why am I talking about diabetes? Thinking about inflammation. Can't your lines? Some of you, your lines are bad. I don't know whether mine too is like that. Your line.
No, please.
Because some of you, when you talk, I can't get. What is no, please, or yes, please?
Please, we can hear you clearly.
Okay, so let's talk about. I just want to do this, summarize this for you, and it's very important for you to know when you are talking about certain things. You need to understand. I want to talk about the pathophysiology of insulin resistance. Pathophysiology of insulin resistance. Pathophysiology of insulin resistance. And this is very, very important. Note this. And you could answer some of the questions that we were talking about. Please, this area is very important. If you don't understand anything, let me know. It will answer why you give statins to a patient. And when you are giving statins to a patient to reduce the C-reactive protein, you can use this to answer that. Okay, so I will start by saying that we have abdominal fat, and this is very important. Abdominal fat. This abdominal fat in the abdomen. This fat in the abdomen is metabolically different from subcutaneous. This abdominal fat, the fat in the abdomen, is metabolically active, different from subcutaneous fat. Hey, this is very important, and this is what is killing us. Especially, listen, pharmacists are at risk of getting this abdominal fat. We are highly at risk. Why? We get home late. When you finish school, you would experience the same thing. You'll be doing your locums. Some of the shops will be closing at 9, at 10. You'll be getting to your house. The moment you get there, you are tired. You just eat and go to bed. Then you'll be seeing our bellies. You don't exercise. You don't wait because you are tired. The moment you sleep, you go to bed. The moment you get home and eat, you go to bed. The moment you get home, eat, you go to bed. You don't exercise. Don't wait for the food. Some even, whilst they are eating, they can fall asleep. It has happened to some of you before. You are so tired that your hands is in the food and you be gone. This is the danger. What happens is that when you build this abdominal fat is metabolically different from subcutaneous fat. And the system don't like abdominal fat because abdominal fat would oppose insulin action at the periphery. We call it lipotoxicity. Abdominal fat is toxic to insulin. Please, I'm emphasizing this, very important. Abdominal fat is toxic to the insulin release. Very important. Metabolically, they are different from subcutaneous fat. So when your abdomen, the adipose tissues in the abdomen becomes full with these fats, and please understand this, your abdomen becomes full with fat, there will be a spill out. And when there's a spill out, this spill out will go and deposit, will get into the muscles, will get into where? Into the liver. And these deposition of abdominal fat in the liver and the muscles would oppose the insulin actions over there, will oppose the insulin actions. So we term it as lipotoxicity. It is toxic to the system by opposing the action of insulin. So we don't need excess of this. So patient with big belly is bad because of these abdominal fats. And when there's a spill out of these abdominal fats, what could happen is that some of these will be released into the bloodstream and they will deposit within the muscles, within the liver. And these deposition will oppose the action of insulin at the periphery. Please, is it clear up to this point? Is it clear up to this point?
Sir, please, could you go over to the part where the fat spills out into the muscle and then the liver? Could you go through that part again?
What I'm saying is that we have adipose tissues at the abdominal region. What I'm saying is that the fat in the adipose tissue in the abdominal region is different, metabolically different from the fat within the subcute. The fat within the abdomen is dangerous. Why? Because they can resist the action of insulin at the periphery. They can resist the action of insulin at the periphery. And therefore, when you have more of the adipose tissue, more of these adipose, the adipose cells within the abdomen, when you are getting more of this, when you are getting more of this, the fat within the adipocytes, when become full, I'm saying that some of these fats will get out. And when some of these fats get out, they will get into the blood and go and deposit within the muscles or within the liver. And these fats, when they deposit over there, then they would oppose the action of insulin at the muscles, at the periphery, or within the liver. Very important. Very important. Therefore, we try to reduce, when you do exercises, try to reduce the fat within the adipose or the cells within the abdomen. When you try to reduce the fat in there won't be any spill out for deposition to occur within the muscles and the liver. Is it okay? Is it okay?
Yes, please.
I should come again at word. Tell me what you understand and what you don't understand. Because what I'm saying is so simple. So come again. What don't you tell me what you understood from what I said? Who can tell me what I've said so far? Clary, tell them.
Okay. So please, we are talking about the pathophysiology of insulin resistance, and we are saying that abdominal fats are metabolically different from subcutaneous fats. So abdominal fats will oppose insulin action at the periphery. So we are also saying that these fats are toxic to insulin release. So the abdominal fat in these adipose tissue, when it becomes too much, it will spill out into the bloodstream, and then it will deposit in the muscle and then into the liver, and then it will get deposited there. So that's what we refer to as lipotoxicity.
So the position over there would oppose insulin action. Is it clear? This is all that. It's so simple. I don't understand why this simple you don't understand. It's so simple. We have fats within the adipose tissues in the abdomen. We have fat as subcutaneous fats over there. The fats within the abdominal fat, I am saying, is metabolically different from the subcutaneous fat under the skin. Abdominal fat is different from the subcutaneous fat. And abdominal fat, I said, is metabolically different from what? From subcutaneous fat. Abdominal fat would oppose insulin action, meaning that it will reduce insulin action at the periphery. So when you have your abdomen here, and the fats within the abdomen, the fats here, the fat here, we have subcutaneous, assuming this is subcutaneous, this is abdomen. We have fat here, we have fat here. When we have, you have your adipose tissues within the abdomen being full. So these are the cells containing the fat in the abdomen region. When these cells are full here, what happens is that there will be a spill out of the abdominal fat into the bloodstream. And when they get into the bloodstream, these fats will go and deposit. So they will deposit some within the liver, some within the muscles. And I'm saying that these abdominal fats would, because they are depositing within the liver, within the muscles, would oppose insulin actions over there. I don't know what I should say again. So abdominal fat is resistant to the anti-lipolytic effect of insulin. I'm confusing you the more. Abdominal fat to oppose insulin action at the periphery. I can also put it in this way. Abdominal fat is resistant to the anti-lipolytic effect of insulin. I told you insulin has this anti-lipolytic effect. Without insulin, the fat will undergo what? Lipolysis. When you have insulin, insulin would inhibit the breakdown of fat. So abdominal fat would resist the anti-lipolytic effect of insulin. All that I'm saying is that you have abdomen, there's a fat in there. You have subcutaneous, there's a fat in there. This abdominal fat is not good. They would oppose, when they are more in the system, they would oppose insulin action at the periphery. And therefore, when you have more of these abdominal fats, and these fats are getting into the bloodstream, these fats will deposit within the muscles. And when they get there and you have insulin in there, you have insulin at the muscles, insulin action will not be felt. They will pause the insulin action within the muscles. And this will term as this insulin resistance at the periphery. Is it clear? I'm going to the next stage, and if you don't understand this, then I have to stop. If you don't understand it, in the next stage, you won't appreciate it. Please, do you understand?
Yes,
Yes,
please.
please.
This is so simple, but if you don't understand this, then the next stage is what I want you to open your eyes well. Open your eyes to get it. Okay, so this is the next stage. Now you have subcutaneous fat and you have abdominal fat. When I say this, and very important, this is adipocytes. This is adipocytes. Adipocytes. Adipocytes are the cells that contains the fat. So when these cells within the abdomen, when they are full, and this is, please understand this, it's not difficult, understand this. When the fats within the adipocytes in the abdominal region, they are full, I said that there will be a spill out. What happens is that when the fats within this adipocytes, when they are full, what happens is that there will be a spill out. That is one. Another thing is that these fats within this will cause stretching of the walls of the cells. It will, because this is full. This is full here. Because this is full, it will cause stretching of the walls of these cells, these cytokines. These cytokines. This is where I want you to understand. So if it becomes full and it's causing the stretch, the excess, there could be a spill out of the excess. But before the spill out, there will be a stretching of this. And the stretching of the walls will cause a release of cytokines. Cytokines. Please, is it clear up to this point?
Yes, please.
So two things. The adipocytes. This adipocytes within the abdomen. Within the abdomen, when it becomes full, these fats within the abdomen, when it becomes full, it will put pressure on the walls. And putting pressure on the walls, it will cause stretching of these outer walls. And causing stretching of these outer walls will cause the release of what you call cytokines. And because these cytokines are coming from these adipocytes, so they are called, some reference will call them adipokines. Some of the reference will call these cytokines adipokines. Others will call these adipocytokines. So we can call it adipokines, or can call it adipocytokines. And these cytokines, and this is what I want you to listen to, these cytokines, different cytokines will be produced, and these cytokines they have different effects, what they will be causing. Some will be causing inflammation, some will be causing thrombosis, some will be causing coagulation. This is what I want you to appreciate. This is why we say that statins has additional benefits, and we are going to talk about these additional benefits, and you appreciate where the additional benefit is coming from. So when I finish, I'll go over, and that will be, I want you to get this. This is very important, very important. I want you to get it such that if you are talking about additional benefit of statin, you would appreciate where it's coming from. And therefore, you won't chew it. Additional benefit of statin, you won't chew it. You won't chew it. So I'm saying this. I am saying that you have these cells, adipose tissues. These adipose tissue contains fat. So in the abdominal region, they have abdominal fat. And this abdominal fat is metabolically different from subcutaneous fat. And I'm saying that when these abdominal region, when we have these, when you have these adipose tissues, and the fat within it are so much. So when they are full, the cells are full with abdominal fat. I'm saying that they will put pressure on the walls to cause the walls to stretch. And as they are causing the walls to stretch, they will release what you call cytokines. And what will happen next is that because they are causing stretching, then some of these fats should come out. So there will be a spill out of some of these fats. And these spill out will get into the bloodstream. And this will deposit within the liver and the peripheral tissue, muscles, and so on. The peripheral tissue. These will deposit. And I'm saying that these fats depositing within the muscles and within the liver would oppose. This insulin cannot stand with these abdominal fats. It's lipotoxic to insulin. It will resist the insulin action. When you have so much abdominal fat at the periphery, it will resist insulin action. And therefore, we don't want this abdominal fat to get into the blood and also deposit within the liver and the muscles. So I said that these cytokines, as a result of stretching of the walls, will be released from the walls of the adipose tissues. And because these cytokines are coming from this adipose tissue, we term it as adipokines. So you could have adipokines or adipocytokines. Adipokines or what? Adipocytokines. adipokines or adipocytokines. This is the name. And I'm saying that these cytokines or adipokines, these adipokines, when they are produced, so we have different cytokines being produced, and these different cytokines have different, they have different effects. They'll cause different effects. Some will cause inflammation. Some will cause thrombosis. Some will cause coagulation, and others. So these cytokines will be causing this inflammation, causing thrombosis, causing and others. And therefore, we have to know the various cytokines that could cause inflammation, cytokines that could cause thrombosis, and cytokines that could lead to what? Coagulation. Please, is it clear up to this point?
Yes, please.
Yes.
So now let's talk about this. One of the cytokines or adipokines that are produced from the release, one of the cytokines, we call this plasminogen activator inhibitor 1. Very important. Very, very important. We call it plasminogen activator inhibitor 1. Plasminogen activator inhibitor 1. One of the cytokines is this. And these cytokines could cause thrombosis. They are pro-thrombotic. They are pro-thrombotic, means that they can cause what? Thrombosis. Please, this is very important. And if I am asking you, this. It took me years to find out question I'm going to ask you. One of our ward rounds with cardio team, and the cardiologist was saying metformin is a cardioprotector. Metformin is a cardio, and was asking the team members, why is it metformin is a cardioprotector? Like saying ACEs are it has a renal protective effect as metformin. So if I ask you, why is metformin has a cardioprotective effect? Who can tell me? Who can tell me? Who can tell me?
Metformin is one, so it is the post-thrombotic effect of it.
I can't hear you. Your lines will come with breaks. You said what?
I was saying that plasminogen activates beta 1, so inhibits the post-thrombotic effect.
So that is what metformin does. Metformin would inhibit plasminogen activator inhibitor 1. So if a cardiologist is talking about cardio effects, they don't want thrombosis to occur within the vessels, within the heart. So if you have an agent that could inhibit plasminogen, which is a cytokine, plasminogen activator inhibitor 1, which is a prothrombotic, then we say it has a cardioprotective effect. Please, is it clear?
Yes, please.
Good. Another cytokine. I'm going to ask you, hey, take this site very, very serious. It will help you. Another cytokine, it's called tumor necrosis factor. Tumor necrosis factor alpha. So we have tumor necrosis factor alpha. Who can tell me what tumor necrosis factor alpha does? Who can tell me? So tumor necrosis factor alpha and interleukin 6. Interleukin 6 is also a cytokine that will be released. Tumor necrosis factor alpha is also a cytokine that will be released from the walls of adipose tissue due to the stretching. So tumor necrosis factor and interleukin 6, these two cytokines will cause what? Will cause inflammation. These two will cause inflammation. Please, you get it. You get it.
Yes, please.
And we have another. We have a lot of them. I can't mention. Let me mention few and go. We have another which is also called resistin. We call resistin. This resistin is also a cytokine. This resistin is also a cytokine that is produced, and this resistin will resist the insulin action at the periphery. Resistin will resist insulin action at the periphery. So now we have resistin. We have interleukin 6, which is anti-inflammatory, which will cause inflammation. TNF alpha will also cause inflammation, and we have plasminogen activator inhibitor 1 that will also cause what? Can also lead to thrombosis. So now these are cytokines being released. Please, is it clear up to this point? Is it clear up to this point?
Yes,
Yes,
please.
Good. Now, if I ask you, we are giving statins. If we are giving statins, additional benefits, we are giving statins. What these statins will do is that these statins will reduce fats that will be in this, that will build up within the adipose tissue within the abdomen. So if this fat is reducing it, it means that there won't be any accumulation for the fats within these cells to be full, such that there will be a stretching to cause the release of these cytokines. And so fat is reducing statins is reducing the fats buildup within this. And if statins is reducing the fat buildup within this, what will happen? What will happen is that there will be no release of cytokines, and therefore there won't be any cytokines that will cause inflammation, and therefore there won't be any C-reactive proteins. So if I say statins will reduce C-reactive proteins, it means that there won't be any cytokines, which is TNF or interleukin 6 coming from these, the stretching, such that if we have interleukin 6 and it's causing inflammation, then there will be C-reactive protein elevation in the system because it's a marker, inflammatory marker. If I'm not having these agents that will cause inflammation, the levels of this will not be high, and therefore we say that statins will reduce C-reactive proteins. Is it clear?
Yes, please.
Again, we are saying that statins will have anti-thrombotic effect. This anti-thrombotic effect is coming from these cytokines. I just want you to picture such that you won't choose some of these. We have other cytokines that will cause coagulation, other cytokines that will cause. So if statins is reducing the fat within us, there won't be any release of cytokines that will cause thrombosis, which is plasminogen activator inhibitor 1. So when I reduce the fat here by using statins, there won't be plasminogen activator inhibitor 1. And when we don't have these, we don't have this in the system, then we are not afraid. That is why we say that statin also has anti-thrombotic effect. Hey, is it clear?
Yes.
Is it clear to the class?
Yes, please.
Okay, so if you don't have any question here, this is what happens. But I want us to learn something from here to complete this. So we have resistant, very important, resistant. This resistant is a cytokine. This resistant also resists the action of insulin, pathophysiology of insulin resistance. This will also resist the action of insulin at the periphery. Action of insulin at the periphery. This is what will happen. The next thing that you should know is that we have bad cytokines and we have good cytokines. We have bad cytokines and good cytokines. The good cytokines, the bad ones are these, the resistance and co. And the good cytokines are, we call it adiponectin. So good cytokines, we call it adiponectin. Adiponectin. These adiponectin are also found within the adipose or within the cells. And what happens is that the more you are increasing, this is very important, the more you are building up fat within the cells, the more you are reducing adiponectin. The more you are exercising to burn the fat within this, the more you are increasing adiponectin, which is a good cytokine. So I'm taking it again. The more you are building up fat within the cells, adipocytes, within adipocytes, the more you are building, the more you are reducing the adiponectin within the cells. And the more you are exercising, that is why we encourage, listen, we encourage diabetics to exercise. The reason is that when you are exercising, we say that exercise would increase sensitivity of insulin. And this is the reason. The reason is that when you are exercising, you are burning the fat within this. And when you are burning the fat, there won't be any spill out that will deposit within the muscles, within the liver. Another thing is that when you are burning the fat, there won't be any cytokines release, which is resistant, because you are burning the fat and there won't be any buildup to cause stretching of the walls. And therefore, there won't be any release of cytokine, which is resistant, to resist the action of what? The action of insulin at the periphery. The third reason is that you will be increasing adiponectin, which is a good cytokine. And the adiponectin has some functions. Is it clear up to this point before I continue?
Yes, please.
Is it for everybody? Is it for everybody or?
Yes, please.
So what adiponectin does is that adiponectin tries to protect the endothelium. It will prevent these monocytes to get attached to the endothelium. Why? Because when this attachment comes, that is where you'll be having this atherosclerosis. These monocytes can damage this endothelium. So adiponectin is there to prevent attachment of these monocytes into the endothelium. And thereby they would maintain the integrity of the endothelium, ensuring that there won't be any atherosclerosis. Because one of the dangers of diabetes is this atherosclerosis. So it's a good cytokine. It will prevent inflammation because of these monocytes hooking onto the endothelium can cause inflammation to that. So it prevents this. So burning the fat, exercising would increase adiponectin and reduce the bile cytokines. In the system, you always have good and bad opposing each other. So depending upon what becomes more in the system, there's checks and balances. So we prefer, like the fats. We have good cholesterol, we have bad cholesterol. They are balanced in the system. So cytokines, you have good cytokines and you have bad cytokines. And these bad and good cytokines should be balanced. So preferably, we want that adiponectin to be higher because it's a good. And when you want it to be higher, one, either you take your statins to deplete the fat within. Two, whether you do exercise to burn out the fat within. And this, the more you burn the fat within the cells, the more you'll be increasing adiponectin. These adiponectin will prevent any attachment of monocyte into the endothelium. That will prevent atherosclerosis. Any question? Any question?
No, please.
Okay, if it's no, please. So what I will do in the next week is to do management. Management of type 2. When you finish with the management, I will do the complications. I'll do the complications of type 2. We talked about complications of type 2 and we said what? It could be hypoglycemia, which we have done. And what? We have
DK.
DK, which is type 1. We're talking about type 2. It could be DK, but it's difficult for type 2 patient to get DK because of the residual beta.
HHS.
So you get HHS, hyperosmolar hyperglycemic state. Get this. Then we do foot ulcers, which is very important. Foot ulcers, which is very, very important. So let's see. I don't know whether weekend I can get time. Then we do this. I want to finish this by next week. So let's see whether weekend I'll be talking to Hillary. I can meet you during weekend. Friday, I don't know whether I can meet. I'm thinking about you are far, far, far ahead of the face-to-face guys, and I can meet them. And tomorrow, until Friday, I want to finish diabetes next week. So, Hillary, let's
Taka. Yes, please. Thank you very much. Have a good night.
Meet during the weekend, then I'll see. If you
Yes,
meet,
please.
I don't know if you could meet. Maybe if it will come on, I'll push it to say 5 p.m. So let's see whether we can do something. We can do now. We can do the medication, which you know already. Biguanide, metformin, sulfonylureas, that you know already. So I'm going to highlight on the salient point.
Yes, please.
So good night.